Hi everyone, hope you're all doing good. Now in this video, we are going to discuss about preconceptional counseling. Okay. So to plan pregnancy and what are the precautions she should take while she is planning to conceive, that is very important to get a well-being fetus and to carry the pregnancy without any complications in the mother also. Okay. So this chapter is very important. This will be giving you so much of basics. Okay. Now we'll start the topic. So, preconceptional period is a vital time to assess and identify various risks and to prevent them from causing the adverse effects on the mother and fetus. Okay. Now, there is a definition given by WHO also. So, what is WHO defines this definition? Okay. So, it is defined as the provision of biomedical behavioral, okay, so it is a biomedical, even a behavioral and social health interventions, okay, to the woman before the conception occurs, okay. Now, there should also be management or any other interventions to reduce the risk factors that are responsible for the poor maternal and child consequences. Okay, so that means we are not only going to identify the problem, we are also going to do some interventions or management of the existing conditions to bring about a better outcome in the mother as well as the fetus, right? So, if we see some of the causes, okay, what are some of the causes that can lead to poor outcome in pregnancy? Okay. So, this may include, number one is when it is an unplanned pregnancy. Okay. We have to be careful about the maternal age. And if there is undernutrition in the mother or any iron deficiency anemia or anemia due to any other cause, okay, anemia due to other causes also. Then if there is any infections, especially sexually transmitted diseases, then any chronic disorders like epilepsy, diabetic mellitus or hypertension, or if there is any alcohol or smoking in the mother. Okay. So, first we will discuss about family planning and contraception. Okay. Because planning of pregnancy is very important. Now, The first point I would like to say is avoiding unplanned and unwanted pregnancies is an integral part of optimizing the pregnancy outcomes. So that's why providing contraception counseling is the first step and a very important point in preconception period. Okay, so giving contraceptive advice. Okay, is the desired step. Okay, we can tell it as a desired first step in preconceptional care. Okay, so when we have young couples, okay, or newlywed, they should be advised on the ideal age of conception. Okay, main thing here is we have to avoid teenage pregnancies. Okay, then so we can give them contraceptive options like either barrier methods or combined hormonal OCPs, etc. Okay, and even we can give them options for a longer interval like long acting reversible contraceptions. Okay, we have levonorgestrel IUCD or copper IUCD devices also. Okay, and another option is implants. Okay, like progesterone implants. Okay, and this is very important even if the woman is having any medical conditions. Okay, like there is diabetic mellitus, hypertension, or she is having epilepsy, or if she is having any heart disease, okay, or HIV, okay, or even psychological illness. Okay, so in this period contraception should be optimized. So until these conditions come under control and it is safe for both the mother and the baby to carry out the pregnancy in a very healthy way, we are not going to advise her to conceive. Okay, we'll see about nutrition. I want to tell you about folic acid here. Okay, so that is one of the essential nutritional supplements we are going to provide in pregnancy. Okay, so all women, okay, whether she is healthy or having any disease ailment, whatever be her age, okay, so all women of childbearing age, when she is planning pregnancy, should be recommended to take folic acid, and the dose is 0.4 milligram per day. Okay, so this is important. And when it should be taken? Okay, it should be taken at least 1 month prior to conception. Okay, and she should continue it for the first 3 months after conception. Okay, that means up to 12 weeks of pregnancy she should continue this. Okay, because this will reduce the risk of neural tube defects. Now, patients who are at risk of these neural tube defects previously itself, that is in the preconceptional period itself, they have to increase the dose of this folic acid, and folic acid should be given at a rate of 1 milligram per day. Okay. So, who are these high risk patients? Number 1, when they have a family history of neural tube defects, okay, maybe in a first degree or second degree relative, okay. Then if there is maternal diabetes, okay, especially when the diabetes is a chronic diabetes, not a gestational diabetes, it is a chronic diabetes, okay, and it can be type 1 or type 2. When there is maternal malabsorption syndrome, we can tell these 3 category of people are at a moderate risk, okay, of neural tube defects. Okay. Now, we will see some of the high risk category, okay. High risk for neural tube defects are seen in women like who have a history of neural tube defect in themselves, okay, or their partner, or if they have a history of neural tube defects in previous pregnancy, when they have a increased BMI, that is more than 30 kilogram per meter square, okay, or if they are a known case of hemoglobinopathies, okay. So, hemoglobinopathies like beta thalassemia, okay. Then suppose if the patient is on anticonvulsants, because in anticonvulsants what is going to happen is, this is going to block the folate metabolism, okay. So, these are the high risk categories. So, we will see it once again. So, this is very important for you because folic acid is an important part in prenatal as well as antenatal care, okay. So, we will be giving folic acid at a dose of 1 milligram per day in patients who are at a high risk, okay. So, moderate risk of neural tube defects are seen in when they have a family history of neural tube defects either in the first degree relatives or the second degree relatives, when there is maternal diabetes, that is type 1 or type 2 diabetes, or when there is a maternal malabsorption syndrome. And who are at a high risk of neural tube defects include when they have a neural tube defects in themselves or their partner, when there is a neural tube defects in their previous pregnancy, when there is a increased BMI like more than 30 kilogram per meter square, when there is a history of hemoglobinopathies, and especially when they are taking anticonvulsants, okay. Yes. Now, we will discuss about anemia, okay. Why it is important? Screening is important, okay. Screening for anemia is important and we will be doing it mostly with the hemoglobin measurement, okay. So this should be a primary screening test. Okay. And it should be treated appropriately. Okay. Now, due to the high incidence of anemia in India, we can even give a weekly supplementation of 100 milligram of elemental iron and 500 milligram of folic acid, okay, and even deworming, okay, with albendazole at a dose of 400 milligram is recommended in the preconceptional period. Okay. So that's why the Ministry of Health and Family Welfare brought about a program called Anemia Mukt Bharat. Okay, or otherwise it is known as AMB program. Okay, so in this program, the supplemental dose of iron and folic acid for various age groups are discussed to prevent anemia. Okay, so how it is taken as, it is considered as a 6x6x6 strategy. Okay, so that means there are 6 groups of beneficiaries, okay, and there are 6 institutional mechanisms and 6 modes of intervention. Okay, so now if we see what are the 6 groups of beneficiaries. Okay, so it is for 6 to 59 months of age children also. So all children will be included in this category, and then it is from the 5 years to 9 years children. Okay, this is another category. Here also will be including all the children. So next is 10 to 19 years age group. Here we are including all children going to school, okay, as well as if there are girls who are not going to school, okay. And from 20 to 24 years, okay, we'll be including the women registered under Mission Parivar Vikas, okay. Then we'll be including all the pregnant females and the lactating females also, okay. So we'll see the iron and folic acid dose in all these categories. In 6 to 59 months of age group people, we are giving an iron dose of 20 milligram and folic acid dose of 100 microgram, okay. And in 5 to 9 years age group, we are giving an iron dose of 45 milligram and the folic acid dose will be 400 microgram, okay. And in 10 to 19 years of age group, okay, and from this age age group, that is from the 10 to 19 years, will be keeping the same dose, that is 60 milligram and 500 microgram. Okay, so it is again 60 milligram, 500 microgram, and here also it is 60 milligram and 500 microgram. Okay, only difference what you want to know is in 6 to 59 months of age group, this is given as a bi-weekly regimen, whereas in all the other categories will be giving it as a weekly. This category it will be a daily. Okay, pregnant females and lactating females it will be daily, and the color of the tablet and the form also changes. Okay, so remember for this age group 6 to 59 months. Now you also have to know in what formulation it is given. Okay, because in this age group we cannot give a tablet definitely, so it is basically given as a liquid bottle with an auto dispenser, and in these categories we will be giving tablet, but the color of the tablet changes. Okay, for example in this 5 to 9 years of age group we will be giving it as a pink tablet, and in 10 to 19 years age group we will be giving it as a blue tablet. Okay, and in these categories we will be giving it as a red color tablet. Okay, so that is very important. For completion's sake, if you ask me what is the 6 interventions, okay, to combat anemia in these categories, these include IFA prophylaxis as we have already discussed, and it may also include deworming. Okay, and we have to give them intensified behavior change. Okay, then anemia testing, okay, by digital methods, and then fortified foods with IFA. Okay, fortified foods, and then we have to rule out other non-nutritional causes of anemia. Okay, like hemoglobinopathies, malaria, etc. Okay, and the 6 institutional mechanisms include intra-ministerial coordination, setting up of a national AMB unit, then national care of excellence and advanced research, that is NCRA, for anemia control. Okay, and we have to, there is a convergence with other ministries also, strengthening the supply, and there is a dashboard digital portal also. Okay, so that will be serving as a one-stop shop on anemia. Okay, next we will see about the body weight. Okay, so that is very important, and we know there are 4 classes of BMI. Okay, it is in kilogram per meter square. So they can be underweight, okay, or normal, or overweight and obese. So the BMI ranges accordingly will be less than 18.5, 18.5 to 24.9, then 25 to 29.9 and more than 30. Okay. We have to advise them to reach a normal BMI range before pregnancy because that is important, and if she is an overweight or obese person, there are increased risk of neural tube defects, okay, the baby having the complication of macrosomia, and there can be a chance of preterm delivery, stillbirth, or even for the mother there can be chances of increased risk of gestational diabetes, hypertensive disorders, and even thrombotic disorders. Okay. So when they are obese, okay, and suppose their BMI is more than for example 32.5 kilogram per meter square and with comorbidities, okay, or suppose even higher BMI like 37.5 kilogram per meter square and even when there are no comorbidities, okay, they can be advised to go for a bariatric surgery before conception, okay, for at least 12 to 18 months after the surgery they have to avoid conception, okay. Similarly, not only in the obese category, when the women are underweight also, okay, you have to screen them for any other psychological issues, okay, like anorexia or bulimia nervosa, because in this category also the same kind of risks, like there can be preterm delivery, okay, the anemia complications and all can be more, okay. And we have to keep an important check on genetics also at this stage, because we have to take a thorough history in the couples, okay, including both the male and female partner, and we have to rule out any risk factors for the genetic abnormalities or chromosomal abnormalities are present, okay. So history taking is very important, okay, and we are going to identify the risk factors, okay. Especially we have to be conscious about the degree of consanguinity between the couples. Then if there is a known hereditary disorder, okay, in the patient or a close relative, we have to be conscious about the ages also. Both advanced maternal and paternal age are going to affect the pregnancy, and even teratogens, okay, including the drugs, infections, radiation exposure in early pregnancy, okay, or even before that, this can affect, okay. And the types of testing we can offer them, okay, we can do a prenatal screening or a prenatal diagnosis test or even pre-implantation testing, okay. And if needed, a carrier screening can also be offered. Now we will discuss something about pre-gestational diabetes mellitus, okay. So in the preconceptional period itself, screening for diabetes is also very important, okay, and the range of plasma glucose in the fasting state should shouldn't be more than 126 milligram per deciliter. Okay. Fasting means no calorie intake for at least 8 to 12 hours. Okay. And the 2-hour postprandial plasma glucose shouldn't be more than 200 milligram per deciliter, and if these criteria are satisfied, then she is considered as a case of pregestational diabetes mellitus. And the risks with pregestational diabetes mellitus include risk of miscarriage. Okay, there can be congenital fetal abnormalities and even fetal death. Okay, and remember the risk in diabetes is more when it is a pregestational diabetes mellitus. With the gestational diabetes mellitus, where it is going to occur after 20 weeks of gestation, okay, generally the baby would have formed and most of the systems would have developed. Okay, so most of the time GDM will not be causing any congenital abnormality or something, only it will be a pregestational diabetes mellitus. And if you are unsure how long she has been diabetic, or if there is a need, even we can go for HbA1c check. Okay, and the range should be less than 6.5%. Okay, next we'll go for thyroid disorders. Okay, for thyroid disorders also a universal screening is desirable. Okay, so the mother can have a hypothyroidism or a hyperthyroidism. In hypothyroidism, there can be maternal, fetal and even neonatal effects. Okay, so iodine intake should be around at least 150 milligram per day, and if needed, an increase in levothyroxine dose. Okay, levothyroxine, that is LT4 dose, should be increased by at least 30%. Okay, 30% increase in dose should be done. Okay, and maybe a referral to endocrinologist may also be done. Okay, next is suppose if she is suffering from hyperthyroidism, the condition should be optimized before pregnancy, and sometimes surgery can be a better option. Okay, now remember the fact that radioactive iodine should not be used in pregnancy. And suppose if radioactive iodine is used, the pregnancy should be advised to get postponed for at least 6 months. Okay, and the drugs which are used for the treatment of hyperthyroidism include propylthiouracil and methimazole. Suppose if she is on methimazole, there is a risk of aplasia cutis in the fetus. Okay, so preferably we will be using propylthiouracil in the first trimester, considering this effect in the fetus. But propylthiouracil also have a high risk of hepatotoxicity. As the first trimester is over, we will be soon putting her again to methimazole. Okay, and then we will discuss something about seizure disorders. Okay, remember there is an increased risk of epileptic frequency in pregnancy. And also there is a potential risk of the anti-epileptic drugs on the fetus. Okay. So if you ask me what is the safest anti-epileptic in pregnancy, we can use levetiracetam first, okay, followed by lamotrigine. Second option will be lamotrigine, okay. And which is the most teratogenic drug, okay, or the drug which is causing most effect on the fetus, okay, among the anti-epileptics means it is sodium valproate. So you are going to get the history from the woman, and when she is on anti-epileptics, you are going to check whether she is on sodium valproate, okay. If sodium valproate is there, immediately this should be replaced by some other drug, okay. And also remember the fact that you have to minimize the number of drugs that the woman is taking, okay, because any kind of drug is going to affect the fetus in one or some other way, because there is a more chance that it is going to diffuse to the placenta. So when she is on a multiple drug therapy, okay, try to change it to a single drug therapy, okay. And what is the other important point we have discussed already? There is a high risk of, yes, very good, there is a high risk of neural tube defects in these patients, okay. What is the dose of folic acid you will give in these patients? Yes, it is 4 milligram dose, and it should be started before 3 months of pregnancy itself, okay, and it will be continued in the first trimester also, that is up to 12 weeks of pregnancy. Yes, clear? Okay. Now we will see about hypertensive disorders, okay. Now hypertensive disorders can be associated with any organ dysfunctions in the mother, or there can be an increased risk of preterm birth, intrauterine growth retardation, or fetal loss, and even they can lead to abruption of placenta, okay. See, these are the risks. So when the woman is having hypertensive disorders for more years, organ dysfunctions, especially renal disease, okay, and cardiac disease, okay, should be ruled out, and even you have to check her for retinopathy, okay. If she is a case of pre-existing hypertension, we should achieve a target blood pressure before conception itself, okay. Suppose if she is uncomplicated case, like there are no organ dysfunction or something, then the minimum blood pressure should be around 150 to 100 millimeter mercury, and if she is a complicated case with the organ dysfunction and all, then it should be around 140 by 90 millimeter mercury, okay. And also the drugs should also be kept a check, okay. Remember ACI inhibitors and angiotensin receptor blockers, okay, or contraindicated pregnancy, okay, because these are going to cause renal damage in the fetus also. Clear? Yes. Now we will see about autoimmune disorders. See, we have to know which is the specific autoimmune disorder the woman is affected with, okay, because the effects depends upon various autoimmune disorders. The most important disorder we have to discuss in this age group of women is SLE, that is systemic lupus erythematosus, okay, because there are both maternal and fetal complications, okay, maternal and fetal complications, like there can be spontaneous abortion or even a recurrent pregnancy loss, okay, there can be IUGR in the fetus or even heart blocks, okay, in the fetus. Suppose if the baby is born, that would be a problem after birth also, and in the mother also there is a high risk of preeclampsia, okay. So, if she is a case of SLE, we should advise her to maintain a state of what we can say it is a quiescent SLE, okay, that means SLE without flares should be maintained at least 6 months before her conception, okay. And as usual, regarding the drugs namely methotrexate and leflunomide that is used for the treatment of SLE are extremely teratogenic. Okay, so what you would advise? It should be discontinued. Okay, now we all know in pregnancy there is a shift from TH1 to TH2, right? So, since SLE is caused by TH1 cells, okay, sorry, it is caused by TH2, okay. So, TH2, there is going to be increased flare during pregnancy, and the other autoimmune diseases that are caused by TH1, okay, like multiple sclerosis, okay, or rheumatoid arthritis, okay, they are going to reduce their effects, okay, means they will improve in pregnancy, okay. So, SLE is going to flare during pregnancy, okay. Next, we will see about bronchial asthma. So, we know the asthma patients are on corticosteroids, right. So, because of this, the effects can be, there can be a risk of preterm labor or a low birth weight babies, okay, and small for gestational age babies also, okay. And in pregnancy also there can be chances of more exacerbations, okay. But the inhaled medications used in asthma, namely beta 2 agonists or steroids, okay, these are considered generally safe in pregnancy and should be advised to be continued also, okay. But a long acting beta agonist, like a solmetrol can be added if the disease is not controlled with the previously taking drugs, okay. And then we also have to discuss about the thrombophilias, okay.